Hi, my name is Dr. Jillian Cotter. I'm an assistant professor at the University of Colorado and a pediatric hospitalist at Children's Hospital, Colorado. On behalf of my study team, I will briefly describe our quality improvement study titled A Multimodal Intervention to Reduce C. difficile Infections and Stool Testing, which was published in Pediatrics. Gastroenteritis is a common reason for children to seek medical care. Clostridioides difficile, or C. diff for short, is the most common cause of hospital-acquired diarrhea and is associated with increased length of stay and higher costs. Over the last decade, many hospitals have transitioned from conventional stool diagnostics to multiplex gastrointestinal panels, or GIPs for short. These panels simultaneously test for more than 20 organisms in the stool, including C. diff. While these panels are rapid, comprehensive, and increase stool pathogen detection, they can be costly and overly sensitive. Diagnosing C. diff infections can be challenging because children have high rates of asymptomatic colonization, which means that C. diff can be detected in their stool even though they have no symptoms, and because the GIP cannot distinguish colonization from true infection. At our institution, the introduction of GIP testing was associated with increased C. diff infections. This was driven in part by increased testing with the GIP, leading to increased C. diff detection and misclassification of colonization as infection. Additionally, lapses in infection control practices and variability in treatment likely contributed to rising rates of C. diff infections. The introduction of GIPs was also associated with increased rates of stool testing, high rates of stool tests with a negative result, which represented low-value stool testing, and no change in clinical outcomes for most children. Due to these unintended consequences, we convened a group to tackle both rising rates of C. diff and GIP overuse. Our primary aims were to reduce hospital-onset C. diff infections and stool test utilization by 20% within 1 year. This was a quality improvement study. Our multidisciplinary team consisted of nurses, pharmacists, physicians, and a process improvement specialist across many fields, including infectious diseases, gastroenterology, oncology, and hospital medicine. We used process mapping and fishbone diagrams to understand the problem and design interventions. Our intervention bundle included 5 approaches. The first 3 were specific to C. diff, and the last 2 addressed both C. diff and GIP overuse. First, we targeted C. diff prevention efforts included increased cleaning of common surfaces, particularly on the oncology unit, where the rate of C. diff was highest. Second, we created a C. diff clinical pathway with testing and treatment recommendations, which promoted increased vancomycin use in alignment with recent studies, and disseminated this pathway through hospital-wide educational efforts. The remaining interventions involved changes in the electronic medical record, or EMR. To reduce C. diff testing when pretest probability was low, we developed an option for GIP testing with or without C. diff, so clinicians could still test for other more common causes of diarrhea without also testing for C. diff. To address inappropriate stool testing due to inappropriate identification of diarrhea, we disseminated an objective definition of diarrhea using a pediatric version of the Bristol Stool Scale. Nurses were taught to document all stool occurrences using this scale. And finally, to reduce inappropriate stool testing in general, we created a clinical decision support tool with 6 evidence-based restrictions based on scenarios that were unlikely to yield positive results or change management. These restrictions were based on data already available in the EMR. The clinical decision support tool provided in-the-moment feedback to clinicians, suggested alternative testing when appropriate, and had an optional approval process if clinicians felt that testing was still warranted. To measure the impact of these interventions, we studied all hospitalized children with stool testing at a large quaternary care children's hospital over 30 months. Our primary outcomes were hospital-onset C. diff infection and overall stool testing. These were measured over time per 10,000 patient days using statistical process control charts. We also evaluated process and balancing measures. This chart shows the rate of C. diff infections on the y-axis and time on the x-axis. The blue dots represent actual values per month, the red line represents the mean value, a change in the red line demonstrates a statistical change, and the dotted black lines represent the upper and lower control limits. Around the time of our interventions, we found a 55% decrease in C. diff infections, which was sustained throughout the study period. This corresponded with a 44% decrease in C. diff positive results and a 48% decrease in testing for C. diff. We also found a 29% decrease in stool testing in general, and this corresponded with a 28% decrease in stool tests with a negative result. The decrease in C. diff positive results which likely represented a high rate of colonization that was inappropriately treated with antibiotics before our interventions, led to more than 1,400 antibiotic days avoided annually. And the decrease in stool tests led to an annual savings of greater than $55,000 from testing reagents alone. There are several limitations of this study. First, restrictions may have resulted in missed cases of C. diff infection. However, the optional override process likely minimized this. Second, the generalizability of our findings may be limited in hospitals without GIPs. However, such hospitals can still use many of the interventions to address the overuse of stool testing. And finally, due to COVID-19, we were unable to evaluate sustainability beyond our 17-month post-intervention phase. In conclusion, we found that targeted prevention efforts, coupled with education that focused on optimal C. diff treatment, and reduced testing when pretest probability for C. diff was low, which decreased misclassification of colonization as infection, all led to a decrease in C. diff infections and antibiotic overuse. Additionally, test restrictions based on a clinical decision support tool, coupled with a standardized definition of diarrhea, led to a decrease in GIP overuse, low-value stool testing, and costs. These findings suggest that a multimodal intervention bundle, including prevention efforts, education, and diagnostic stewardship strategies, can lead to a significant and sustained decrease in C. diff, can improve the judicious use of diagnostics, and can promote the delivery of high-value care for hospitalized children. For more information or questions on this study, please feel free to reach out to me directly.